I looked over Dr. Stoner's slides, and I'll do the best to do them justice. I did notice that he's only included 3 topics: syphilis, gonorrhea, and chlamydia. So I'm hoping if I don't run out of time that we will maybe leave some extra time to talk about other STIs, HPV and herpes in particular, since that's often a popular topic. So here are our disclosures. Dr. Stoner has no financial relationships. I do know a little bit about him. He's both younger and better looking than I am. And he works at, I believe, for the Washington University, St. Louis in their medical school, but he's also one of the physician consultants and trainers with the St. Louis-based STD training and HIV prevention training centers, which there used to be a network of 12 or 15 of these around the country, and now they're down to 3 or 4, I think. But so they actually cover the Wisconsin as part of their territory for providing training for STIs, and that's why he was able to come or not come and speak to us today. I am a speaker from Merck, but we're not going to be covering, unless we talk about HPV vaccine today, that won't matter much. So, what are STIs? Really, what are we talking about? Most of us have this perception of what are STIs are those diseases that you get from having intercourse. And I hope one thing I want to expand on today is that the definition is much, much bigger than that. And remember that when 2 bodies interact in some sort of way, whether you're shaking hands, you're kissing someone, or you're sharing a drink, you're exchanging organisms all the time. It doesn't matter if those body parts are genitals or those body parts are hands. We exchange organisms with each other all the time. And the only thing that's different about these is the social and cultural implications and factors that go into the fact that they're sexual transmission instead of other things. But from the organism's point of view, it really isn't any different. So, we do spend a lot of money in this country on managing STIs. There was a recent paper that was published just a month ago looking at this issue, and I believe the figure was over $6 billion a year with a B. I get this question a lot too. What's the preferred term? And it actually comes down to your personal preference. In my talks, I tend to interchange the acronyms a lot, so I apologize in advance for that. But there is supposed to be a definition now. There are 2 ways to approach this. One is what the definition means. Sexually transmitted disease has been around for about 30, 40 years and implies disease, consequence, bad outcomes. Sexually transmitted infection is a newer term that's becoming more popular because it recognizes that many things are transmittable but don't always cause disease. And among those, things like, as Dr. Hatcher was mentioning this morning, so many of these infections are asymptomatic. HPV being the primary example, most people with HPV infection never develop any disease, never have any consequence, never develop any bad outcomes at all. It is perhaps less stigmatizing. And I think among college students now, if I use the term STD, I sometimes get corrected by my patients. So the other way of approaching this is I think it's a generational thing. People over 50 tend to use terms STD a lot. People under 50, maybe, are more likely to use STI. And finally, there's a sort of a public governmental approach. If you work for the CDC, you use STD, and almost everyone else in the United States uses STI. So here are some numbers. These are actually old. In that same paper that published the data about cost, we now have updated statistics, although they haven't changed a lot. But the data now are current through 2008. They were published in the Journal of Sexually Transmitted Diseases in February, if you want to look it up. The total STD prevalence and incidence has not really changed that much. About 19 to 20 million incident cases of STI a year. The vast majority of these, by the way, are due to HPV infection. So probably 14 to 15 million out of the 19 or 20 million are HPV infections. So they really overwhelm everything. So if you want to scare people and talk about how 1 in 4 US adults has an STI and 1 in 2 college students has an STI, then you use numbers like this and you don't sort of get into that nuance. But really, many of the things we're talking about are actually quite infrequent and quite rare, including syphilis and gonorrhea, relative to how they were a long time ago. So the first clinical topic that he put in here was syphilis, and I know a lot of you probably don't see a lot of syphilis, so this should be a good review for you. Syphilis is caused by a bacteria. It's a spirochete. The other major spirochetes in our lives are the organisms that cause Lyme disease and borreliosis. They are actually very closely related. And if you have Lyme disease, you can actually have a false positive screening test for syphilis. That's how closely related they are. This is not something you can grow in a laboratory. You really can only rely on serologic tests, and as we go into the future, probably molecular tests will become available. They're not at this point. So, and it's an exclusively human pathogen, so you cannot transmit this to your animals. Not that you would. So, you may remember from school, so syphilis has 3 classic stages of disease: primary, secondary, and tertiary. So does Lyme disease, by the way. Primary infection is the local infection. This is where the person acquires the organism through their skin or tissue, and it produces classically a large open chancre, and there are going to be some pictures here. Why is it the STI talks are usually right after lunch? Secondary, if that infection is not treated promptly, the infection becomes systemic, and the organism is seeded everywhere and will classically cause a systemic rash that is very characteristic. But much like measles and rubella, a lot of providers in the United States have never seen a case of syphilis and have no idea what that rash looks like except from talks like this in textbooks. Tertiary syphilis, fortunately, has become a very, very rare disease in the United States. Most syphilis infections, even if they're untreated, will resolve on their own. And unfortunately, we know that that was one of the outcomes that we learned from the infamous Tuskegee studies. About 30%, though, of syphilis infections do progress to neurosyphilis if they're left untreated. And finally, there's this other classification that's called latent syphilis, and that simply means someone who has syphilis in any of these stages but has no symptoms at all. That you just have a positive blood test and no history of any symptoms or no current symptoms. And latent syphilis can persist for many years. And again, sometimes it'll resolve. So a little bit of data. Probably not a lot of you were in this room were alive during World War II, but before the penicillin era, syphilis was a huge problem. It was probably it was the HPV of the 19th century. I mean, it was a pervasive STI. Everybody knew about it. Lots of famous people got syphilis. It was all over the place. And then with the introduction of penicillin in the World War II, syphilis incidence plummeted not only in the United States, but around the world. And has really stayed there pretty low. This is a really good historical perspective on what's going on. So there was this little blip in the early 90s. That blip was mostly tied to a crack cocaine epidemic, and where those drug users were often co-infected, if you will, with syphilis. Syphilis is not a uniform disease. Its epidemiology has very distinct geographic characteristics. Historically, in the southeast part of the United States, have the highest case rates. This is true also for gonorrhea and chlamydia, but not to quite so much the same degree. I don't know what the current figure is, but in the last decade or so, you can look this up on the CDC's website, but there's something like 95% of the syphilis cases in the United States come from a dozen or 20 counties in the country. It's a very, very focal disease, and those are mostly large urban areas and rural areas in the southeast. So there are a couple people here from DPH. Even in Wisconsin, this figure is something very similar. 95% of the cases of syphilis come from Madison, Milwaukee, and Green Bay, and most Wisconsin counties have not had a case of syphilis in the last year. Lori Ann, that's approximately correct. 6 zip codes in Milwaukee County, a large proportion of the syphilis cases in Wisconsin. So many of you don't see this. So tell me, for show of hands, in the last year, how many of you have personally seen a patient with confirmed case of syphilis? So there are about 5, 10 hands in the room. Now, of those folks, how many of those were heterosexual patients? Am I not seeing a single hand? I had one. And we'll talk about that in a little bit. So we saw this semester, we saw a college student with syphilis who had female partners, And that was the first heterosexual patient I've seen with syphilis in probably 20 years. So. And this sort of reflects, this is the male to female ratio. So this is showing you that males predominate 8 to 1 for cases of syphilis currently in the United States. This is almost all men who have sex with men. In the United States right now and for the last few years, we don't have a lot of syphilis, but what syphilis we do have is overwhelmingly in that population, probably 90% of the cases of syphilis. Men who have sex with men have a roughly 60-fold higher incidence of syphilis than men who have sex with women. That has big implications for testing, for screening. Here's what a primary chancre looks like. These tend to be large, dime-sized to quarter-sized, nasty, look absolutely horrible, usually painless, classically painless. If these occur around the anus or sometimes in the introitus in women, however, they can become secondarily infected and they will be painful. The chancres I've seen in the last few years have usually been perianal lesions, and they look a lot like a bad fissure. They're not actually this large. And I've missed both of them. I mean, clinically, I missed both of them. I thought they were fissures. There's a small one. There's a perianal one. A little subtle on the photograph. So. All right. So this is not a very great shot, but this is what the classic rash of secondary syphilis looks like, palms and soles. These are brownish red macules. Classic, almost nothing else in medicine causes this. So if you have a patient walk in, or even on the phone describe this to you, you can make the diagnosis without the blood test. You do need to do the blood test because you need to confirm it. But if you saw a patient with this presenting symptom, you treat them in the clinic with bicillin today. You don't need to wait. Those other lesions, maybe. Better picture. Here it is on a different part of the body. I can't tell what that is. These can also cause mucus patches on mucous membranes. That's what this is showing you. I've seen that. And there's a type of secondary syphilis called condyloma lata, which actually looks a lot like genital warts. Essentially indistinguishable from warts. The difference is you give that patient a shot of bicillin, and those lesions all disappear in a week. It's magic. You wish they were warts. Wish you could treat warts like that. Diagnosis. Traditional dark field microscopy is a great way. You can identify the lesions. You can actually see the spirochetes. Nobody can do this anymore. I doubt anybody in this room has access to a dark field microscope in your clinic. Probably not even your reference lab can do this for you anymore. So forget about doing this. It's just simply, in the real world, dark field microscopy is not available to us any longer. So we're relying on serologic tests, screening tests, confirmatory tests, either an RPR or a VDRL. The differences between them are not important. Whatever your lab offers or whatever your clinic does is fine. These are non-specific screening tests. They can produce false positives, and they always have to be confirmed before you diagnose somebody with syphilis. And the confirmatory tests are known as an FTA or a TPPA. The TPPA test, which is, I can't remember what the acronym stands, treponemal something antigen, antibody. These are much more specific tests. They are specific to the organism. They are more expensive and more labor-intensive to run, so they're not used as screening tests generally. Most labs now are going to doing a TPPA. So the thing to remember, if you do have somebody, you do a blood test, it comes back reactive for a VDRL or an RPR, your lab should automatically be running these confirmatory tests for you. If not, you'll need to order it. Here's what the spirochete looks like. It is actually spiral. They burrow into the tissue like a corkscrew. Now, there's a new test on the scene, and some of you may have had experience with this. This is the old way we used to do it. This is what most STD clinics, what most family planning clinics, with most primary care clinics are still using. You do a screening test, a non-specific test like an RPR or VDRL, and you confirm it with a treponemal test. The non-treponemal tests, even in people who are successfully treated, often will revert back to zero or non-reactive. That's important to know. And so you use this test in RPR or VDRL to monitor treatment also, because you want to see that titer declining. The treponemal test, by contrast, will always be positive, generally, for the rest of their lives. So that's another reason why you can't use it as a screening test. You can never tell if somebody's been reinfected by doing that. It will always be positive. And you should tell them that, because the next time they get tested somewhere else, you don't want that provider to have to freak out because that comes back positive. So here's what's new. There are newer tests on the market now that are being done. They're an EIA test or an ELISA test. These actually are specific. These are like the treponemal tests, like the TPPA. But we do the opposite. So these are called reverse algorithm tests, because you start with a specific test, and if it's positive, it still has to be confirmed, but now you're going back to the traditional RPR VDRL. Why do people do this? This is being done by large laboratories, particularly laboratories that serve plasma centers and Red Cross and other places. It's very, very cheap. It costs them pennies to run this test. It doesn't, the VRL and the RPRs are very labor intensive, take a lot of laboratorian effort and time, so that's why they've moved to this. But they have a lot of problems with specificity. There are lots of false positives. The CDC has put out and published an algorithm for managing these. This is showing you how the RPR and the VRLs are done. You have to titer them out. It takes a long time, 6 to 8 hours typically. But these newer tests are not very good for managing infection. There's lots of discrepant results. But you're probably going to start seeing them. This is what the algorithm is. So the problem happens if you have a positive EIA and a negative RPR. It's probably a false positive EIA, but in some cases could be something else. And so the CDC has recommended the management of that and going through the algorithm if you see these. We see them coming into us because people get tested somewhere else, like a plasma center with a positive EIA, and they're referred to us to figure out what to do and if they need to get treated. But just be cautious. Now, it is up to the laboratories are supposed to be running through that whole algorithm themselves and repeating the test with multiple methods to confirm whether it's a real infection or not. Treatment of syphilis has not changed in 60 years. We still use plain old penicillin. The organism does not develop any resistance. So it's still a great, it's one of the few things I think we use penicillin for at all. Lots of penicillin, though. It's a large dose. Anybody who's given this knows how fun it can be. This is a little bit like Elmer's glue, 2 large syringes in the butt, and not comfortable for the patient at all. Oh, and if the other thing, when we're treating patients, it doesn't matter what stage they're in, primary, secondary, tertiary, but it does matter how long they've had their infection. So that we have these other distinctions between early syphilis and late syphilis. And early syphilis simply means any case that you can document the infection has been present less than 12 months. You give a single dose of bicillin, that's early syphilis. If you can't document that they've had their infection for less than 12 months, and this usually is the case if you pick up a positive on a routine screen and no prior screening, then you're supposed to treat as if it's late syphilis or late duration. It's been there more than a year. You give 3 doses a week apart. Most of my patients never come back for their 2nd or 3rd dose, though. If you're allergic to penicillin, you can take doxycycline for 2 weeks. That would be contraindicated in pregnancy. And the CDC guidelines say in that situation you should do desensitization or confirm their allergy, because a lot of penicillin allergies are actually not true allergies. So. Gonorrhea. So we're moving up the incidence scale. So I said syphilis is not very common. Maybe, if I remember the numbers from that chart, I think it said 50, 60,000 cases in the US. Gonorrhea now, we're talking maybe a couple 100,000 estimated cases in the US. When I started working in the Student Health Service a long, long time ago, we routinely saw 30 to 40 cases of gonorrhea a month in our student population. Last year, we saw 22. And so it's been a big change in the incidence of this disease as well, and I'm sure that it's reflected in what you see in your clinics. Gonorrhea, also a bacteria. This is an intracellular organism. Classically causes an acute urethritis in males. When males acquire gonorrhea infection in their urethras, they almost always will have a symptomatic presentation. This is very different than chlamydia, right? Where chlamydia is often asymptomatic. Urethral gonorrhea is usually symptomatic, but technically not always. And often in women is not symptomatic. So much like chlamydia in women, gonorrhea can be asymptomatic or causes cervicitis, but not cause any acute pain. Here's the incidence data for gonorrhea. When I show this slide, I like to point out that I don't have a, if I push a button on here that's going to do something bad, then I'll, anyway. I started PA school in 1979, so I clearly am personally responsible for this. I saw my first STD patient when I was a PA student in 1979, and it's been downhill ever since then. So. But we are relatively stable with gonorrhea rates right now, and it's much like a lot of other diseases. We wish we were on the verge of elimination of gonorrhea and syphilis, but we just can't seem to get over that last hump. Much like syphilis, but not completely, gonorrhea is much more prevalent in men who have sex with men in the US right now. That's not true always in other countries. The other thing is gonorrhea has, much like syphilis, has a lot of geographic variability, much more common in large urban centers, and actually quite unusual in smaller communities and rural areas. Chlamydia, by contrast, is sort of a universal problem everywhere. But unlike syphilis, the male-female ratio here, as you can see, is actually kind of very similar. But again, here's that geographic distribution showing, much like syphilis, rates much, much higher in the southeast part of the United States. But you see the rates are much higher than they are for syphilis. So here's a picture of a classic, again, gonococcal urethritis. When men have gonococcal urethritis, they typically always come in and complain. The primary symptom is urethral discharge with dysuria. Oftentimes, the discharge is literally flowing out of the penis. They'll come in with a tissue wrapped around their penis to soak it up. This also can, of course, cause a cervicitis, and the cervix does the same thing. It's red, it's beefy, it's dripping yellow pus. So classically, the differences between gonorrhea and chlamydia. Gonorrhea tends to be a very purulent discharge, yellow, green, thick. Chlamydia tends to be mucopurulent or mucoid, so it's thin, clear, or white, and often very scant. And this says gonococcal cervicitis with scant, purulent exudate in the os. So this might look almost normal to you, but cervicitis, we'll talk, I think there's a slide in here about treating cervicitis itself. Cervicitis, mucopurulent cervicitis in women is the simple equivalent of urethritis in men, or non-gonococcal urethritis in men. Most of those infections are sexually acquired. They're usually caused by either gonorrhea, chlamydia, or one of the other pathogens. Oh, a Bartholin's abscess, one of the most common causes from that actually is gonorrhea as well. But we don't see this a whole lot anymore either. So. One of the complications, of course, and Dr. Hatcher was talking about this morning, is PID. It used to be thought that gonorrhea was probably much more likely to cause PID. And this is a tubal ovarian abscess. But we now know, because chlamydia is far more prevalent, and at least in our population and many populations, our chlamydia incidence outnumbers gonorrhea 10 to 1. And so chlamydia in the US really probably causes far more infertility and pelvic inflammatory disease than gonorrhea does. Gonorrhea can also become disseminated. Much like other Neisseria species, meningitis, and so on, you can get a systemic distribution with lesions, violaceous or these sort of really dark lesions, and as well as arthritis. Those are really pretty unusual conditions. Diagnosis of gonorrhea actually used to be really straightforward. So Gram stain is a great way to find gonorrhea. Unfortunately, Gram stain is not a CLIA wave procedure. Most of us can't do Gram stains in the clinic anymore. CLIA says providers are not capable of doing them. You have to send them to a certified laboratory and have the laboratorian do the Gram stain for you, which is unfortunate, because if you can do this in the clinic, you can figure out right away whether that discharge is gonorrhea or not gonorrhea, because the organism is very easy to see, but it isn't really available to most people anymore. And if you're going to send it out, it's really a stat test. It's helping you figure out while your patient's in the room what drugs are they going to get today? And if you can't do it on site, then don't bother. We've all come to rely now on using nucleic acid amplification tests for the primary diagnosis of both gonorrhea and chlamydia. These have largely replaced culture. Really is the gold standard test of choice. You can find very few organisms. These tests are extremely sensitive and very, very specific. In real life terms, probably approach 100% specificity and maybe at least 99% sensitivity. So here's what a gram stain looks like. A lot of white cells. The big blobs are all white cells, polys. And the gonococcus is the little kidney diplos. They're kidney bean shaped, pink, gram negative. Very easy to find if you can do this. Here's a color shot, a better one. So in the old days, we did cultures. You know, we would put them in candle jars, and they love CO2, and that's why we do that. But the sensitivity of culture for gonorrhea is actually pretty low. And these days, most of us are doing this only for non-genital sites when we can't do nucleic acid amplification tests. Treatment of gonorrhea has changed recently, and this is probably the most important slide in this section, so make sure you know if you don't already. Gonorrhea is treated with dual therapy. This is the same approach that we use for treating TB and HIV and lots of other things. On his slide here, he says we're adding an anti-chlamydia therapy. That's true, but the primary reason this is being done is to stave off resistance to cephalosporins. So even if your patient has a negative chlamydia test, you still give the dual regimen, okay? And that's very important to understand. You're not only treating chlamydia, you're treating gonorrhea with this regimen. So it's a single injection of ceftriaxone, 250 milligrams, plus either azithromycin or doxycycline. Clinical hint. Ceftriaxone comes as a powder and has to be reconstituted. You should or could use lidocaine for that. It's much, much more comfortable for the patient. This is a very uncomfortable injection if you do it with saline. And it is right there in the package insert if you didn't rip it up and throw it away. So it comes in a small vial, reconstitute it with 0.9 mLs of lidocaine. It takes a long time to dissolve. Inject that. We give them in the deltoid. A lot of people give them in the gluteal site. Doesn't really matter. It's a small enough dose. It's a 1 ml dose. Then you can certainly give it in the deltoid. The only time I give it in the gluteus is if the patient's very small and very thin, has very small deltoid muscles. So, and then give them either dispense the azithromycin or give them a script. They should take it the same day. The idea here again is dual therapy. You really don't want to wait until that chlamydia test comes back. It's not ceftriaxone today and azithromycin next week. It's both drugs today. So what's going on with gonorrhea resistance? Well, gonorrhea, the organism, has been resistant to everything that's thrown at it. That's its normal thing. A lot of people are referring to this as a superbug, but it's just being a normal gonorrhea. So gonorrhea has been developing resistance to every antibiotic we've ever used for it. Probably the problem with that is that those mutations and the resistance to those antibiotics is cumulative. So a gonorrhea infection that someone gets today is still resistant to plain old penicillin, amoxicillin, ciprofloxacin, everything we've used, doxycycline. So penicillin, this is an old slide from the 40s. Not so much anymore. Here's what's going on. Originally, we started using sulfa drugs. Again, after World War II, penicillin was introduced, tetracyclines. Gradual increase in the MICs, the minimal inhibitory concentration. That's how we measure resistance. Ceftriaxone was first recommended in 1989. It wasn't used a lot. A lot of people still like using amoxicillin. Quinolones. Quinolones were a great drug. Oral cefixime, single pill, very easy to take. It was great. Great times. And now we're back to giving shots again. And I know a lot of you don't like giving shots, or a lot of clinics, it increases the risk of needle stick injuries to you. It's more uncomfortable for the patient. Be glad you're not in Japan, where the standard treatment, my understanding, the standard treatment for gonorrhea now is IV antibiotics. Part of the reason for that is Japan, a couple years ago, had the first documented case of ceftriaxone-resistant gonorrhea in a prostitute, oral infection. Fortunately, that's not clinically resistant as well as MICs. So what we know is, in fact, the MICs, which again, the minimal inhibitory concentration, this is how we determine resistance, that value has been climbing for the last decade around the world. So it's not that we have resistance right now, per se, against cephalosporins, but the amount of antibiotic it takes to kill off the average organism has been climbing over time. And there will be a point, not may, but probably will be a point in the next decade when most isolates of gonorrhea are resistant to 250 milligrams of ceftriaxone. In other words, that will not clinically resolve the infection or cure the infection. And again, that's the reason why we use dual therapy, why that recommendation was put into place a year and a half ago. How do we know this is going on? This is the GIST project. It's an interesting epidemiologic study where they still have to do culture because you can only measure MICs if you have a live organism. So one of the problems with not using culture anymore is that very few laboratories have the capacity to tell you, to even run these tests, or to tell you if there's resistance. On your NAT test that we're all doing, you'll never know if it's resistant or not resistant. You have to rely on this study to tell you. So they're scattered around the country. They monitor a number of isolates. They submit them all to a central laboratory. But this is what's been going on. The gold bars are men who have sex with men. The more orange bars are men who have sex with women. And this is, over time, looking at the proportion of isolates that are relatively resistant to Cipro. And this is why we stopped recommending Cipro in 2007. Believe it or not, I talk to the health department, my local health department, on an almost daily basis about patients. And probably a couple times a year, they tell me that there's a provider in Madison who is still using ciprofloxacin to treat a case of gonorrhea. And they're usually telling me this because they're arranging to send the patient to our clinic to get treated correctly. Here are what the MICs are for oral cefixime in that study. And you can basically see that this is still relatively sensitive at this level at 0.015, but there's this gradual increase over time, the purple bars being the most recent study compared to 2009. So here are the current recommendations from the MMWR. I just want to point out, if you use the recommended regimen of ceftriaxone plus azithromycin, you don't do test of cure. If you have to use one of these alternative regimens, which is either oral cefixime plus azithromycin or azithromycin, then you're supposed to have them come back in a week and do a test of cure. So this is kind of a new recommendation. If you use the preferred drug, ceftriaxone, no test of cure. If you use anything except ceftriaxone, do a test of cure. When would you use azithromycin? The only situation where it's indicated is if the patient has a documented allergy to a cephalosporin, and you shouldn't give ceftriaxone. Then you give them 2-gram dose of azithromycin and hope they don't throw it up. Most of them will. So this is a problem. I've had to use it once. Okay? So you shouldn't use that azithromycin 2-gram alone. It's really not a recommended therapy by itself. It's really only reserved for patients who are documented to be cephalosporin allergic. Can you give ceftriaxone to someone who says they have a penicillin allergy? How many people would say yes? 1. How many would say no? How many have no idea? So there used to be this concept, and it really is a myth, that if you are allergic to penicillin, you are also allergic to cephalosporins. That's not true. About 10% of people with penicillin allergies have a cross-reaction to the first-generation cephalosporins. But that relationship doesn't exist with third-generation cephalosporins like ceftriaxone. Okay, so you are totally fine giving somebody with a penicillin allergy ceftriaxone. You don't have to worry about that. only if they have a documented cephalosporin allergy. And if you're not sure, you could get them tested. The patient I had been told since childhood that he was allergic to cephalosporin and got a rash from it. And that's why we went with this alternative regimen. Question?
How are you handling expedited partner therapy?
Great question. How do you handle expedited partner therapy for gonorrhea? My personal opinion is you can't do it anymore. For gonorrhea. You should make every attempt, for gonorrhea, you should make every attempt to get the partner into the clinic so they can get an injection of ceftriaxone. If that's absolutely not going to happen or can't, you can legally use EPT and give Cefixime, but it's no longer preferred. Right. So the EPT legislation in Wisconsin was developed before these recommendations came out. It's unfortunate, but at the time we were still using Cefixime, was a great drug of choice for treating oral Cefixime, 400 milligrams, great choice for treating gonorrhea, and great choice for using EPT for gonorrhea. But then the recommendations changed. So you should really avoid using Cefixime. The thinking is that when cephalosporin resistance develops in the US, we're going to see it happen with Cefixime first, because already its MICs are higher than they are for ceftriaxone. So again, old-fashioned way, but this is what's recommended for test of cure because, as many of you know, the NAT tests are so super sensitive, they will pick up residual organism and DNA because you don't have to have a live organism for NAT test to be positive. The test is looking for a segment of DNA. And that has a couple of other implications, if I'll try to remember what to mention that. However, the thinking is that with gonorrhea infection, people probably clear GC out of their tissue faster than they do with chlamydia. And some people are saying that probably you get by doing a NAT test even a couple of weeks after treatment. With chlamydia, as you may know, you really should wait a while, preferably 4 to 6 weeks. All right, chlamydia. Well, let me say the other thing about the NAT test right now is, again, when you have a positive NAT test, does that mean the person has a live replicating infection? It does not. It means segments of DNA were detected on a test. That could either be deposition from a partner, it could be a resolved infection, or it could be a live current infection. So especially if you see someone shortly after sexual activity, the next morning or something, that's always something to keep in mind. We treat them as if they have a real infection. We have to assume that, but understand in some cases that the organism could have just deposited and is not yet an infection. It's more of a minor kind of technical point. All right, the third thing on the slides, chlamydia. And really, we should spend most of our time on this because chlamydia is far, far more prevalent, right? You all see it, I see it, we see it at health service. I was telling Dr. Hatcher at lunch, 1 case a day in our student health service. 40,000 students. We see about 20,000 students a year. We do 6,000 chlamydia tests a year, roughly. So about 300 to 400 positive tests a year. That's our volume. Chlamydia is a very interesting organism. It's closely related to other rickettsia, like Rocky Mountain spotted fever and some other things. It's very small. It's virus-sized. You can't see it under the light microscope. And like a virus, it's an obligate intracellular organism. It doesn't survive on its own, so it infects white cells. Epithelial cells. Other species of chlamydia cause other diseases, including pneumonia. Here's the incidence data over time for chlamydia. This has been looked at a lot. We think this rise is actually increased testing and increased positivity on the better lab tests. This probably, the actual true incidence rate of chlamydia in the United States is probably relatively stable. It is the most prevalent reportable STD there is. It's the most prevalent disease that the CDC tracks. About 2 million cases a year estimated to occur in the United States. So after HPV, chlamydia is the next most prevalent STD. Geographic distribution, much more uniform. Again, these case rates, incidence rates are about 5 times higher than gonorrhea. And in our clinic, it's about 10 times higher. Clinical presentation, non-gonococcal urethritis in men or women. Only about 40% of the time, though. So most chlamydia infections in both men and women are asymptomatic. And I would say compared to gonorrhea, in men, chlamydia tends to present more commonly as a vague urethral irritation, sometimes urethral itching, not always frank discharge, not always frank dysuria. It's sort of on a continuum. Women can have the same thing. Key pearl, woman comes in with what you think is a UTI. If she's at risk for chlamydia, especially if she's had partner change, multiple partners in the last 3 months, you should be screening for chlamydia also. Very, very important. A lot of chlamydia in women presents as dysuria, not as vaginitis. And if you're not thinking of that, you'll miss it. I guess if we had these two discharges side by side, you'd see this one, I guess, is supposed to be more mucoid. White cells, no organisms. Here's a gram stain. So again, you do the gram stain. Guy comes in the clinic with discharge. You can do a gram stain. Do you give him ceftriaxone or not? This is what I would base it on. But again, most of us can't do this anymore. Also can cause infection in the cervix. Classically, a mucopurulent discharge coming out of the cervix. But like gonorrhea, the test of choice is a NAT test, nucleic acid amplification, for the same reasons. Super sensitive test, very, very specific, very good. Treating chlamydia alone, azithromycin still is the primary drug of choice we're using. Doxycycline is a good alternative. Compliance is much, much lower. There is at least one quinolone, levofloxacin, that's approved for treating chlamydia. It's much, much more expensive. I can't think of any reason why anybody should ever use that unless you are allergic to azithromycin and doxycycline, because it's about 10 times the cost. There have been some recent reports in the literature of azithromycin failures with chlamydia, especially in men with acute symptoms. In one study, it was only 77% efficacious. So this is being hotly debated sort of among the national experts. I do have an approach for this. If you see people who were symptomatic and they got azithromycin and they return with persistent symptoms, if you can rule out reinfection, then you should switch them to doxycycline. Okay? That's if their chlamydia test was positive. We still like using azithromycin as the first-line drug, though, because there are other organisms that cause urethritis in men, including Mycoplasma genitalium, which is not something most of us can test for, but is thought to account for probably another 25–30% of urethritis infections and probably cervicitis infections. Doxycycline does not work very well for that organism. So when you have a patient presenting with just clinically urethritis, probably azithromycin is still the right thing to use. So a little bit about, yes?
Do you have any idea what the rationale is, why they're not responding to the azithromycin? We just had a patient seen in urgent care ER, positive chlamydia, treated with Zith. Within a week, called back and said, I'm not better. The same thing's absolutely no chance of reinfection. They just phoned him in another zithromycin. Then he showed up in our clinic, still symptomatic. We tested him, and he was still positive.
So he gets doxycycline?
Yes. But is there, I mean, what is it, the resistance to?
There's a lot, this isn't well known. There are probably a couple reasons. One is there may be an absorption issue with azithromycin. For whatever reason, that patient is not getting systemic levels of azithromycin in their urinary secretions or their prostate, perhaps, to eradicate it. Nobody's really sure. There does not seem to be any resistance. It's not, the organism itself is not resistant that we know about. The other thing is that it seems to be related to what's, for a better term, we'll call organism load. So this seems to be more problematic in people with frank, acute, classic urethritis, lots of discharge, lots of dysuria. It could be that they simply need a larger dose, and we don't know that. There hasn't been a clinical trial to sort of evaluate that. And I hear both of those theories out there, that's what people are thinking. So that is, so for your asymptomatic patient, azithromycin seems to work perfectly fine. It's mostly these guys coming in with acute urethritis who are not resolving. But it is important to rule out reinfection because the most common reason people get their symptoms back is they had sex with an untreated partner. And that's why EPT is important. It's why following up and treating partners at the health department level is so important. So, Here's something, if you don't know about this, this is a project that started out of Johns Hopkins in Baltimore, distributing kits, home kits to patients to test themselves for gonorrhea and chlamydia. It actually has been a really rousing success. It's not widely available. It's available at select places, select states. And Wisconsin's not one of them, so I don't think you can use this, but it's been very popular. And so the reason I think it's in here is because I think this is really where things are going with a lot of routine screening for chlamydia, that people who won't come into the clinic or can't come into the clinic will have options to be tested at home. Whether this would go over the counter like we have for HIV tests and other things, I don't know. But it does offer a new way to get more people tested. So the chlamydia prevalence in this population was quite high. So that's about double the national average for positivity. Here are the places where it's currently available. So there might be somebody here from Illinois. I don't know which counties those are, though. Has anybody been doing this, sending kits home with self-collected vaginal swabs home with patients, maybe for test of cure or for rescreening? We've been talking about it. So self-collected vaginal swabs are recognized now as probably the specimen of choice, if it's available to you, for doing chlamydia testing, even in the clinic. It has higher sensitivity than doing either a cervical swab or a first void urine. And so if you're doing this in the clinic, it still should be patient-collected, not provider-collected. So you send her to the restroom, and she gets it's a blind swab of the vagina, and patients seem to accept this more than doing urines. At least in one study, that was their finding. So, and I'm going to have Michelle say something about Michelle Smith from State Lab. For those of you who use State Lab, they are, I think, getting ready to do this, and the hope is maybe by this summer, self-collected vaginal swabs will be available to those clinics that are using State Lab for their chlamydia testing. So stay tuned to hear more about that. Or I can repeat your answer.
The latest I can tell you from the State Lab is we're talking about it, and Dave Warschauer and Audrey Prevey we're going to be partnering with University of Ohio, I believe, to get some residual samples in so we can do the verification and validation studies that we need to do. So we are moving forward on that. So that's good.
Yeah. So one thing people have been talking about with that is this is kind of useful because if you're having a patient you're treating for chlamydia, you could send her home with the swab kit to do her rescreen, which is another recommendation for both gonorrhea, chlamydia, and trich, is to bring women back, and men, 3 months after their diagnosis and rescreen them. That's not a test of cure. That's to identify new infection and reinfection. Rescreening rates, particularly for the home testing, was much, much higher than people returning to the clinic. I don't think that doesn't surprise me much. So. And then finally for extragenital testing, so this refers to testing of rectal sites and the pharynx for gonorrhea and chlamydia. Currently, screening of the rectal gonorrhea and chlamydia is recommended only for men who have sex with men. Pharyngeal screening for gonorrhea is recommended for men who have sex with men. Pharyngeal screening for chlamydia is not currently recommended for anyone. And that has a lot to do with not having good tests that can test the throat. There's very little knowledge about the epidemiology or the biology of chlamydia in the throat. I think that's all going to change over the next few years. We probably will be looking at down the road where we will be screening people at any exposed site. Right now, I think the value of doing it for men who have sex with men, particularly for gonorrhea, is, again, gonorrhea is much, much more prevalent in men who have sex with men. Rectal infection can cause fairly significant symptoms. Pharyngeal infection is probably important only as a reservoir for persisting infection in their sexual networks. That is, that people don't really get a pharyngitis, they don't really have any problems, but they can infect partners. So here's some data from a study looking at testing those extragenital sites. Most of these studies are done in men who have sex with men. This one was not, but looking at women and finding actually a fair number of infections. This shouldn't surprise any of us. If you have infection in your cervix from a penis, you're going to get an infection that you acquired from a penis or a penile transmission event. You're going to have that infection at any other body site as well. Now, if you identify it at one place and you're treating it, then you don't really have to worry about that because it's going to cover it everywhere. So this is in your handout. And particularly, I think the point here is that oral pharynx infection by itself was actually quite rare. Most of these were combined infections with cervical site. All right, I'm going to skip over a couple of that. This is looking at MSM data, same sort of thing. None of most of the NAT tests you use in your clinic are not approved by the FDA, cleared by the FDA for using for non-genital sites. And in order for a laboratory to perform them, they have to go through a validation procedure, much as Michelle was just talking about with the self-collected vaginal swabs. The larger commercial labs have all largely done this. Many of the smaller labs have not. State lab has not at this point. But again, down the road, we expect to have that soon. And yeah. But if you're seeing men who have sex with men as patients, you should be asking about history of receptive anal sex. And if the answer to that question is yes, you should be screening rectal sites for gonorrhea and chlamydia. That's a standard and current recommendation. For all other patients, it's kind of more your decision whether you do it or not. All right. Summary, syphilis, gonorrhea, and chlamydia patterns are dynamic and changing. That's certainly very true over, especially if you look at a 30 or 40-year time period. So, antimicrobial resistance is making a big difference, I think, particularly with gonorrhea. And the issue that's really scaring all of us is there really are no other drugs in the pipeline after ceftriaxone. So we don't know what we're going to use next. And there's only one clinical trial underway right now to evaluate that for gonorrhea. So hopefully we'll find something. All right, I'm going to stop there. We have only a couple minutes left. I can take some questions about other STIs if you have something specific. Or I'd invite Jan up to answer questions, or if she wants. Where she? Yeah.
We've had 3 cases of gonorrhea reported in females to us at Public Health in the last 8-9 months that have been positive off of cytology fluid. One of the most recent ones had a negative GC swab and then a positive cytology. She was positive for chlamydia on the swab that the practitioner had done. All 3 females were asymptomatic with asymptomatic partners. 2 of them had their partners treated without testing, and the other one is pending, but they're all asymptomatic, the males as well as the females. Could you speak to this, please?
Yeah, I've not used that product. There is, I think, at least one company out there that offers this as a multiplexing process, is what it's called, where from a single test they can run NATs on gonorrhea, chlamydia, trick, as well as doing this HPV typing or positivity, and then technically, I think the cytology is a different test, but Michelle might be able to speak to that a little bit. It seems to be a growing thing, and that, I believe, is probably one of the most expensive ways to do your gonorrhea testing, just because this product is very expensive. But I think from a health department perspective, you would probably have to take it at face value and say it's a true positive. I mean, yes.
Yeah. Yeah, when we looked at it, I mean, one of the problems with doing the chlamydia and GC out of the vial, of the thin prep vial or the SurePath vial, is the protocols that have to be put in place, because it's very, very easy to cross-contaminate. So it's possible that it might have been the one before that then contaminated 3 more. And that's one of the reasons why we have, and Bobby, bring Bobby back in, and you will remember her saying, no, 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 never do chlamydia gonorrhea out of the vial, just because the cross-contamination is really difficult to control.
You know, and the other thing, every now and then we get questions, and probably local public health departments get this all the time, from somebody who was tested for gonorrhea, or chlamydia for that matter, and says, there's no way I can have this. And my first response, why were they, if that's really true, why were they being screened in the first place? And the answer is because a lot of providers do STI screening in people who are at no risk and shouldn't be screened in the first place. And there are false positive tests for both gonorrhea and chlamydia with gnats. They're not 100% specific, and that's important to keep that in mind sometimes. Our approach to that usually, when we've had a few of those every year where we suspect, I mean, there's no risk factors, there's really, the story isn't right. We treat them anyway. But sometimes we'll tell the patient, look, there's a possibility this could be a false positive. If you call your laboratory that's running the gnat, sometimes they can tell you where on the scale the cutoff was. And sometimes, you know, it's just right over the line. It's basically a low-value positive, and then that gives you a little more faith that maybe it was a false positive.
Just to clarify, so if I had a patient who I treated today for cervicitis, and so I gave her a gram of Zithromax. She comes back next week positive for gonorrhea alone. When I get her in for treatment, do you still treat with both?
Good question. So I think I would probably just give her ceftriaxone at that point. I think I've encountered this happening once, a very similar situation. Actually, I think it was a male. Because in our clinic, we don't see a lot of gonorrhea, so any guy who walks in with discharge is presumed to have chlamydia first. And he was treated for his chlamydia infection, tested for both, and his gonorrhea then came back positive, and he was brought in a few days later, 5 days later, to get his ceftriaxone. I think that's probably fine. You don't ideally want to do it that way when you're treating gonorrhea, but I don't think it's worth a second course of azithro, but it's a data-free zone, so I don't think anybody really knows the right answer.
Thank you.
All right, well, thanks very much for your attention, and hope I was able to cover Dr. Stoner's material okay.